what brought you into this world? Because you're a physiotherapist first, and you treat and work with a variety of individuals with a variety of reasons and needs for all of their joints and muscular concerns. What brought you into this specialty certification of pelvic health?
So it would have been similar in having some personal experiences. My first pregnancy, I think that I was a little bit naive during the pregnancy portion. I knew what pelvic physio was. I even knew probably more than or definitely more than the average person about core strengthening and some of the different things to keep in mind while you are pregnant. However, I just sort of assumed that because I exercised and I did core strengthening, that I wasn't going to have any problems. So I didn't pay any more attention to it than that. And I didn't really have, I would say, what I like leaking or out of the ordinary pelvic symptoms while pregnant. But then I had quite a traumatic delivery, which I mean, I think happens, but people also don't anticipate or think ahead about to be proactive with. And then after the fact, just sort of healing and trying to get back into activities. So even just like walks with a baby or whatever it was literally like I woke up one day and had all these symptoms. Oh God. And it was kind of terrifying. So that didn't even, at the time, I still thought that it wasn't necessarily something I wanted to do, but that I knew where to go. So I went to a pelvic physio and got some support with it, and I learned a lot doing that. And there was some frustration in that sort of interim period with lack of medical care, I guess. I feel like I missed the boat on the postpartum follow-ups, and part of that might have been a COVID era thing. However, yeah, I guess there was symptoms and things that I'd never even heard about or knew could be problems after delivering. So that was one thing that always stood out for me. And I think what was the sort of tipping point? Well, so the first one being that if I'm in the profession and sort of still had that lack of awareness or education, what is the average person who's going through that period aware of or being told or not being told? So we're sort of only reacting when there's a problem, right? And not thinking about doing anything ahead of time. And then the second one was, so I think it was after, I don't remember when I did the course, I think it was after my daughter. So I went into second pregnancy a little bit differently, lots of tools up my sleeve, also a little bit terrified about the delivery again. I took, just for something to do while I was off work, they had a course called like non-internal. So it was a pelvic floor course for physiotherapists who didn't want to start doing that, but wanted to learn a little bit more about what kinds of education they could provide or what they could do before feeling like they needed to refer to somebody who did do the full kind of examination process. And I think in the last probably year, I've had maybe a handful of patients where they were in for something else, but I think one was a pregnant patient, so she was here for something totally unrelated, but just in talking, I kind of provided some education. There was a postpartum patient who just wanted to get sort of back to some exercising, and just providing them with like a few little tidbits that made me think that I hadn't really offered them very much. Like the feedback I got back from that was, oh my God, that was so helpful. And So it was just sort of a bit enlightening in that that in combination with there's such a big demand and not a lot of people that offer it in the area. I thought if I'm just missing that extra piece of doing the whole thing, yeah, so that's where it sort of brought me.
Well, I think the fact that you have the personal experience, it doesn't exclude humans, but when we have this personal experience and the relatability to our patients, I think that is huge. And we can have the compassion and the understanding, and then the frustrations and everything else that goes with it. And then, of course, the medical system, right? There's, this isn't about um, criticizing the medical system, but there is a reality to our medical system right now in Canada. And the preventative care that is not available or understood. After having our babies, the only thing I ever understood was do my Kegels and work on my core strength, and really truly understanding that. And then after the babies, like I wasn't doing it until now. Here I am, almost 20 to 30 years later, and I'm recognizing there's a problem. And could it have been prevented? And I think that's also why I really wanted to speak to you too, because I often think about my younger self, or even you, who's 15 years ahead of me or behind me, and not just yourself, you are educated in this, but what we can offer to women in their 30s after babies.
Exactly.
Yeah. So can you tell me let's start with what is the pelvic floor? Can you explain that? And, what weakens it?
The best way to explain it, if I see if I can get this in the camera. So if you picture my little model, most people refer to the pelvic floor as this sort of like the bowl part in the bottom. So the collection of muscles that kind of come around, if you think of it like a hammock underneath your pelvis, that's the bottom support. And so there's lots of different analogies around like picturing a hammock, and over time, if you're adding a lot of weight on top, and it starts like sagging on this bottom bowl. But as you can see, there's all kinds of, if I take our little organs out, muscles underneath, lots of layers, different muscles that make up that function. And their role is to support our pelvic organs, which would be the rectum at the back. For women, the uterus in the middle.
Kelsey, can you lift that up just a little bit? I can't quite see.
The uterus in the middle, and then the bladder.
Oh boy.
Yeah, which
there's lots in there.
Hard to do and hold up, but they do go in there and look a little bit more anatomical. And then the other thing to think about, so that would be, I guess, like the general definition of the pelvic floor would be the muscles, and then the ligaments and the fascia that attach into the bones. But if you wanted to think of it a little broader, it is a part of your core, and your core would make up also all your muscles of the abdominal wall at the front, and then all the muscles that support your spine in the back. And then you have your diaphragm. So if you picture like a balloon that sits on top here, which is your big muscle that helps us breathe. So that's, I love that, what it is. Some of the different roles would be, like I said, to support those pelvic organs, but also support our continence. So adding pressure to the sphincters to control bladder and bowel function. There's also a sexual function, a blood flow function. So there is some type of what they call sump pump effect from the bottom. That's some of the and then providing stability to the spine as well.
What is the pelvic floor? What is it attached to on either side? What bones?
You're looking at so this is your sacrum. So you have attachments into the hip, mostly the sacrum, the coccyx, and then the pelvis at the front. But you will see like some ligaments that would attach into the base of the lumbar spine as well.
So that would then explain if there is a weakness in the pelvic floor, every point where the hammock is attached could pull on those joints and create pain. And perhaps we wouldn't recognize that it's the pelvic floor, but we think it's our back or our hips. Or
and there's lots of referral patterns, and a lot of the really, really deep muscles of the hip that rotate the hip and kind of have a role in the pelvis as well, have kind of referral patterns all the way down the back of the leg, into the back, into the hip, tailbone pain, people with a lot of chronic, like which is the coccyx, but what they would describe as tailbone pain that just sort of doesn't go away, can all be affected by either like weakness or tension in those muscles. I have two other things. So these were what we help use to visualize like how we're doing an exam, but just to give you a visualization. So again, this would be the base from the bottom of the female, this like bowl. And that's sort of the deepest layer of all the muscles. So there's a lot going on. And then this is like the middle layer from the opposite side where you're getting those sphincter muscles that contract, and then the superficial layer would be the muscles that you can kind of palpate more on the outside
that can then stimulate deeper in. Okay, which we can maybe chat about in a second, because I'm super curious about that. So talking about the women at the campfire, when we step into this perimenopausal period in our lives into menopause and estrogen starts dropping, and we generally understand that our muscles begin to weaken or lessen, and a lot of the different things happen as a result of us reducing estrogen. Can you talk to us more about what really is happening within the pelvic floor, and what I like to say, the symphony of...
Yeah, no, and that's a perfect way to think about it, is that sort of connection of all of that working together. But the biggest thing is with the decrease in estrogen, is how it affects like the soft tissue and the connective tissue. So it used to be called just vulvar atrophy is what happened. The vulva being the tissues basically like on the outside of the vagina, and they would just atrophy. But part of that is it's like a thinning process essentially as well. And then with that, you get kind of a decreased like resilience to the connective tissue in general. So on top of the thinning happening, you've got decreased blood flow. So people complain of like dryness, itching, which you wouldn't necessarily think would be relevant to function, except that then you're creating a lot of pain, and then pain kind of brings on a whole plethora of other things. Sometimes if you had a lot of pain, you might be like tensing your muscles or reacting a certain way. But I think those were sort of the biggest take-home points, is that sort of lack of resiliency to the supportive tissues. And that can kind of come out either like two ways or in a combination of ways. So weakness or tension. Sometimes it's that you lack the kind of flexibility or suppleness to the tissues as well. So And then, of course, a combination of both. And then because of that, because you're lacking that like hammock support on the bottom, pelvic organ prolapse is a lot more common. That can happen like for women who've delivered vaginally and have that trauma, but then it can happen just because of that lack of support. So it's something like, I believe they said 50% of women over 50 have some level of pelvic organ prolapse. So that's like, I guess if you picture, yeah, that bowl, and we can get in, like, that might be a whole other topic, but there's different types of prolapse. But if you're picturing that bowl and there's just not enough like support up, or it's yeah, sag. I don't know if sag's the right word, but lacking support, there's more space for things to like sink deeper and deeper into it.
Is there a domino effect if this is dropping and then everything that you kind of put into the bowl, does that all then drop down too? Is
So
that what adds the pressure when we talk about incontinence?
it can be a variety of things, but sometimes it's the pressure of, say, like the urethra, which is where you urinate from, so that like tip of the bladder. Sometimes it's just that sensation of pressure, so you're feeling that heaviness, that fullness, and it might be kind of mixing up your perception of what you're feeling. But the prolapse itself can be, and it just kind of depends on what's the weak point in any individual, but it can be the bladder, in women, in the uterus, it can just be the vaginal wall, so that the organs are kind of sitting where they should, but you get this like caving in of the tissues that are normally like a solid wall, or the rectum that starts to press in, sort of that like posterior vaginal wall is lacking support. The rectum can start to like press in that way. So then like that was a whole other topic again. Yeah, so there's a lot going on, and then what you get off, and then that's where we can like talk about the link to hip pain, back pain, is whether so not other and those kind of people are kind of seeing it.
You're sitting there going, I should know this. We've been in this world for a long time, and then to actually experience it though and understand what's happening, it's amazing. It's really, really amazing. What what other what other symptoms of pelvic floor dysfunction would, like, so we talked a little bit about how do we know the difference of low back achy, especially how about this one, if you've always had a low back that would get inflamed in different periods of time, but it began when you first were pregnant with one of your babies. Like, and so how do we know, what are these symptoms? What are symptoms that we can look for?
I mean, sometimes it could just be like a chronic low back thing that was correlated with that, and you did all the other work and it just never really went with. Maybe there's something else that we're not quite getting at. But often that kind of comes hand in hand with other symptoms. Leaking is a big one. Incontinence, it can be, I think, like urinary is more common, but bowel also exists. And there's different types, but the two sort of main categories would be what we call stress incontinence. So that would be people noticing that they leak, and it can be a small amount, it can be a bigger amount with that big change in pressure. So jumping, just skipping rope, running, coughing, sneezing. So involuntary kind of things that happen, and losing that reaction back or control. Urge is another one. So people that have really strong urges that come on really rapidly and then feel uncontrollable. So sometimes by the time they realize they have to go and they're on the way to the bathroom, they're leaking just on the way. So those would be the big ones. And then those symptoms of like the pressure, the heaviness, sometimes so say someone did have a prolapse that was significant, they might even notice some like tissue or something that they can feel
Okay.
down. Other things would be chronic constipation might be one, so or incomplete emptying. So they feel like they're going but not feeling like that everything has been um, emptied properly. So that frequency, like you're having to go more often than what is normal, would be another big thing. I think those are the big ones. Maybe sometimes difficulty like initiating going or relaxing enough. So people that might get there and then have trouble starting, and then pain as well. So they shouldn't really be painful processes. You shouldn't have painful bladder or painful bowel unless there's some infection or something else going on. But say you've ruled those things out, it shouldn't really be a painful process. I think those would be the biggest.
Well, it's so interesting because in our past history or my understanding, any of those components I would have put to something happening in my digestive and not thinking that it was anything connected to my muscles or possibly prolapsing, etc.
And it can be like digestion plays a role, and it's something that we can, provide people with resources on whatever they need for that. But sometimes it's as simple as like, well, how do you go to the bathroom, and do you need to strain, and do you need to, and just teaching them that both bowel and bladder function is are muscles that your pelvic floor muscles need to relax to allow you to completely go. So you shouldn't be straining. And in fact, like even positioning can make an impact. So they talk about putting your feet up on a stool, which puts your hips into an optimal position to just relax your pelvic floor muscles and allow yourself to. A lot of people don't know that. I mean, I didn't know that.
Yeah, it really is amazing. So what would happen if an appointment with you, this is a very, I love this because I had mentioned that I was going to be chatting with you to my mother. And I often think about this as as you go through menopause and the whole journey of menopause, you recognize all women for years and years and decades have been going through menopause. And then you go through it and you go, oh my gosh, it's kind of like having a baby too. You don't realize how encompassing having a baby can be. And the same, and the same goes for menopause. You start seeing all of these things happen, but there's not a textbook like birth and pregnancies. There's no, we can follow some guidelines. And so when I spoke to my mom and talked about pelvic health, she was shocked that there even was this this service, this information, this possibility. And I think in their generation, it was just surgery. Until life had become and my point is, had become so embarrassing. And there's a shameful component to all of this that perhaps generations have been passed down. And so this is also where I have a lot of motivation and so excited to be speaking to you, because it's about getting information out. It's about not being shameful about what we're going through. And it's about having these conversations. So not only can we have a better, a more wholesome experience, a more um, aware experience, but then we can also shift things for our daughters and our granddaughters and our great granddaughters. So with that, what would an appointment look like with you, and what happens? And
So if somebody books an appointment, they will get sent a big long list of questions, and are forewarned that it is quite lengthy, but not everything applies to everybody. So, that's one thing is we say skip over what's not relevant to you or you're not comfortable answering. Sort of what you were touching on there was uh, whether it's shame, embarrassment, but there's lots of things that I think people don't think to talk about for those reasons. So certainly, I want it to be at the patient's comfort level, but that's how it would start. It gives me a little bit of a background going into it of where to lead the assessment. That being said, we still would start with a bit of a subjective interview, either reviewing those things if I have any questions to clarify, um, talking a little bit about what their goals or expectations or what they want out of it is. And then in terms of the actual assessment, and part of that would also be reviewing the process of consent, which we would get into a little bit about. There are some contraindications or risks or reasons why people may not be appropriate, so making sure that that's not the case. And then, they taught us to look like any physio, really, or assessment or condition. If someone comes in with, say, an ankle injury, you're going to look at the knee, you're going to look at the lower body and how it's working. So similarly, I would still do a bit of like a low back screen, see what low back and hip mobility looks like. And then depending on the case, like if the patient is interested in the internal exam process and we think that that would be really beneficial, of course, that never has to be an absolute. So there's lots of things we can do externally or exercises we can go over just based off of their subjective information. So I might assume, for example, when somebody might have symptoms of weakness, let's say they're getting that pressure, that sagging, that stress incontinence. However, I'm not going to know for sure unless I can do an internal exam and actually grade the strength. So kind of having that discussion, and then if they're open to it, generally the internal examination would involve palpating the different muscles, all those ones that were on that bottom of that bowl, and feeling for what the muscle tone feels like. So like I said, some people's problem is that they're actually very, very tense there and the muscles aren't able to relax enough. Or is anything really painful? Is it referring anywhere? And then like any other muscle, working on that. And then assessing the strength. So generally we do like a global, what we call strength assessment, different cues on doing the muscle contractions. And then I feel, can they, so if this is my fingers like this, do you feel the pelvic floor lift when they contract? How long can they hold it? We use like a 0 to 5 strength scale, which is standard across any muscle assessment. And then how many times can they repeat that? So with about 10 seconds in between. And then can they do quick contractions with the ability to let go in between? And that's where you see a lot of, maybe on the first go, somebody feels nice and strong. Oh, that's not that bad. But then it gets all uncoordinated as they're moving along, and then they're not relaxing or they're holding their breath, or you can feel other muscle groups coming in with that. And then after that, you go into, depending on what you found, what you might want to work on. So as much as it's can probably be a really intimidating thing, the actual internal component is not very long, generally speaking. And it doesn't then need to always happen at every appointment, but gives you that information of what is actually going on and what they might need to work on first, and then plan that way.
And your environment, I would think, and you just as the human that you are, it's relaxed and very very kind and gentle, but very knowledgeable and professional as well in your processes through it. As you're saying that though, Kelsey, like, is the fact that all muscles operate the same in the sense that they all need to go through a form of contraction and relaxation. And in order to build it, I used to say, we used to minorly tear the muscles to allow them then to build by stressing them and then allowing them to build. How would you explain that? Like, is this the same?
Well, and that's it. And that's, I think, like a good explanation for people is that they're muscles like everywhere else. And yes, we have muscles in our body. Some are those what we call mover muscles. So they turn on when we need to use them. Like, say I need to turn my head, and then they should turn off. And then we have the deeper stability muscles that are more endurance, and they're kind of there all the time. So there are different muscles that do different things, but at the end of the day, they can all lose their synergy or their ability to coordinate properly. They can be weak, or they can be tight, or they can have tender points and cause pain or referred pain. It's just like everywhere else. It's just that people don't really think about having muscles there.
No. And with that same theory, then, whenever we do any sort of strength training or we want to build, or let's say we have some weakness in our right shoulder and we're working on muscles around the shoulder girdle and front, back, and stretching out our pecs, or whatever that combination might be, we are on a plan to work those muscles maybe twice a week, 3 times a week, and consistently work on building. Is this the same approach?
Pretty much, yeah.
Wow.
There's a lot, I wouldn't say a lot more, that's not necessarily true, but there might be more sort of lifestyle and education pieces involved that could impact things. So
like what?
So one thing we might do is give someone what's called a bladder diary. So if they're having different symptoms of incontinence, but not if you think of the bladder as also a muscle, and if you're afraid of being incontinent or being out in public and having that urge come on, so you're going to the bathroom just in case, even if your bladder's not completely full, and that those muscles aren't learning to expand to their full capacity. So part of that could be looking at someone's like bladder health, how much they're drinking and how often they're going and for how long, and teach them strategies to try and wait a little bit and allow that like full filling capacity, and then try to have a full void. So up to like 8 to 10 if you counted Mississippi. And what always sort of shocks me is the regular amount of times people should urinate in a day is 5 to 8. And yeah, even it's not that much. And not at night. You shouldn't have to until I'm trying to remember the age. I think it's over 50 once at night.
Okay.
But it shouldn't be more than that.
So we should be able to hold for 8 hours or whatever we
Overnight.
should. Hmm.
Yeah. Now, the other thing that they did mention or to think about would be um, what they call bladder irritant. So if you're drinking coffee or tea all morning long, then you are going to be going more frequently because that's kind of irritating that tissue. But then again, like that might be something people need to look at if they want to.
Oh, I think it's so
Mhm,
helpful. It's
mhm.
the knowledge. It's like when you know better, you do better. But if
Yeah,
we don't,
yeah,
we
exactly.
can't. And thinking about that, what are some proactive things that is there anything else when we think about somebody younger, and or even in my age group, and what would be good motivation? Like, why should we be doing these sort of things?
I think that I mean, the one thing that kind of comes to mind, and um, a friend actually reminded me of this fact, but and I know you're working with like an over 40 population, and that's still a long way from, let's say, being 80. However, the number one reason people are admitted to long-term care is incontinence. So um,
Oh,
it's kind of terrifying if you think of it that way. Um, and then I think it's, super impactful on lifestyle as well. If or your, quality of life is what I meant by that. Because nobody wants to like be worried, like I want to go out for a run, but I'm worried about where I'm going to be or how far I might need to get and need a bathroom kind of thing. So
yes.
I think there's some motivation in that. I think too, like if you're going through something like a pregnancy or preparing for childbirth, being proactive is important. Just thinking about like the stress that happens to that hole, and so doing as much as you can to um, build that strength up. And then the other thing I guess is that pain is kind of does a funny thing to the brain. So even if you think about any other part of the body, muscles don't always work optimally when somebody has a lot of discomfort or um, whatever's going on in that hole. So sometimes, like just having people focus on that awareness of normally when you cough or sneeze, those muscles like react instinctively. Um, but if that's not happening anymore, you can just have people try and be more aware of that. So let's say
Hmm.
you are having symptoms. I know we can't always feel something like a cough or a sneeze coming on, but if you did sort of feel it, like work on that muscle contraction that we've gone over, usually starting with me internally so that they can feel what they're doing. And then if you can, do it before, then your brain's going to pick that up and eventually get back to the point that it's happening automatically without having to think about it.
Yeah,
So
it's
I don't
amazing.
know, a bit of a tangent or don't really answer your question.
No, it
Yeah.
is so, so great and it's so helpful. When you were talking about that though, when we're talking about going back to being, for myself anyways, going back to being pregnant, that is such an amazing thought. If I had known that there was a resource that could have assisted me, perhaps during my pregnancies, before or after, however,
Hmm.
that I could be proactive as my body did age. And of course, we feel invincible for many years until we're not, or recognize we're not.
Hmm.
It could, is that something for a pregnant woman to come and work with a physiotherapist on their pelvic health?
Absolutely. Yeah. And that's kind of, I think, was part of my personal experience was I I knew sort of what type of core strengthening, but I was really only thinking the core, not necessarily
Mhm.
the pelvic floor. And just having people, whether they might already be strong or still strong, but working on that awareness and muscle control through those different areas, the bladder, the vagina, and the rectum, and that strength. And then applying that in different positions. Because if you think of a pregnant woman, so now they might have this nice strong bowl on the bottom, but eventually that uterus that's nice and small in my model is going to grow and grow and grow with that baby. And that pressure that's kind of coming down on top, like you, your body can only do so much with that once you're adding all that weight and kind of something else. So, as much as I didn't have any like incontinence or any symptoms during my first pregnancy, after I delivered, it was kind of like I couldn't feel anything, like whether that was the trauma to the area, and that's what we call proprioception. So if you think about any muscle or joint in your body, your proprioception is your body's ability to kind of feel what's happening, whether it's a joint moving in space or that you've contracted the muscle, you've relaxed it, like you can fully feel what's happening. And it was sort of like I can tell that there's weakness there and that I'm not, like, things have been, stretched and traumatized and stitched and all that. But even the cues to give people about how to do the pelvic floor contractions, I would sit there and try, and I couldn't feel what I was doing. Like I just lost that. So I think if I'd been a lot more specific about working on that in the first place, even not realizing that there might be a problem, maybe I'd have had like proprioception after the fact or been left in a better place. It's kind of like even people that we have that we know are going for a hip or a knee replacement. They're going because obviously we know that they've had this degeneration of the joint cartilage over time and often have a lot of pain or stiffness or dysfunction. And so you do as much work ahead of time as you can. And not everybody knows that. But the people that do, the people that get as strong as they can going into surgery have the best outcomes. And so, but I think we don't think to apply it in this case. But, but well, again, like why?
All of this being as old as time and women's health, that it's just always been. And these components, as you're talking though, I've got to say, episiotomies must be, it's one thing to go through an episiotomy, which I went through 4 times. How, that must be so traumatic. Listen to me, I'm asking you, and I've lived it. Like, I mean, for what that would have done to the muscles in my body.
And going back to that, they're muscles just like everywhere else. So now you've torn them, you've attached them back together, and now you've created scar tissue, which sometimes is painful for people. It tends to be kind of stiffer and less flexible, especially initially. And then scar tissue, when it initially heals, they grade the type of collagen, which is a component of what makes up our soft tissue. So they call it this like low quality collagen. So instead of these nice sort of like aligned fibers, they're sort of like this. And that's what makes it kind of stiff and uncomfortable. And then there's work you can do that remodels it and makes it what they call like the good grade connective tissue. But again, like you don't think of it in that area.
Yeah, and there's no conversation about it.
Or again, the preventative, like a episiotomy is one thing because you can prevent that, but tearing that might occur during childbirth just from like the force of the baby coming out. Teaching someone like a perineal massage at I'm going to say starting around 36 weeks. Don't quote me on that. I'd have to look it back up, but I think that's about right. And just preparing that tissue to stretch. Like, okay.
Wow.
Yeah,
Yeah,
there's
again.
like really good evidence that that can help prevent high grade tearing. And
Mm,
yeah, that didn't have a
yeah.
problem at first, so I didn't think to massage my yeah.
Yeah. It's interesting. But again, if we can be offering this to
Mm-hmm.
new moms and or old moms
Mm-hmm.
like me,
Mm-hmm.
and the
Yeah,
understanding that we can work on this. This is
yes,
muscular.
exactly. Yeah.
Yeah.
And I think that's again going back to like why, as much as I never thought I would be the one, um, you know, palpating people that way for a living, it is kind of, I would say, still not really natural to think about yet. However, it just is like, it's not hard. And I think there's not enough of awareness and things happening that could so easily prevent or help people.
It's wonderful. I think it's great. And the more that we can get out there and people can access, imagine the healing and the less trauma and the less pain
Mm-hmm.
that women don't have to be going through,
Yeah,
and prioritizing themselves and taking care of
yeah.
themselves.
So I was just going to say, I think that's one of the
Hmm.
big myths out there too. And um, I don't know exactly. I think it's come a long way in maybe the medical profession, but um, you hear all the time that, oh, well, I leak doing whatever activity, but that's because I had three babies. And they just think that
Exactly.
they know why, but they think that's normal. And sort of a big take home point that came out of some of the training was it might be common, but it is not normal. So don't like make it um, that there's nothing you can do about it.
Yeah, absolutely. We taking care of ourselves and
Mm-hmm.
recognizing that just because, again, as we talk about our mothers and our grandmothers and our great grandmothers, they might have done things a certain way and stated it as normal, but it's not, and we
Mm-hmm.
don't have to suffer, which is
And they probably
amazing.
never would have talked about the symptoms of incontinence as well.
Hmm. Hmm.
That, things are
No,
changing that way too. But
no. Oh, thank you. Um, I was wondering if you might, when we think about homework and learning and understanding ourselves a little bit better, I was wondering if there might be an exercise that you could talk me through, or us listening, the sisters at the campfire, that might be
mhm.
something that we can become more aware.
I think that a good place to start, and it might seem um, kind of simple, but is diaphragm breathing, because that will help anybody, regardless of what the symptoms or conditions are. And a lot of even the strengthening exercises kind of stem on being able to do that breath. And a lot of people, I think, don't actually know how to do it properly. The other thing that it does is it sort of stimulates your parasympathetic parasympathetic nervous system. So I think with lifestyle, people are so busy and running around, and everyone's in
Yeah.
that fight or flight state all day long. And um, that might be more the population with that extra sort of tone in the pelvic floor. However, um, the diaphragm breath kind of switches your body's gears out of that state. So I think it's a good place to start. And then what, so I'll start there, and then I'll tell you how you can even just start to think about your pelvic floor with that breath. So
Perfect.
the first thing would be, you probably can't really see me, but if you put your one hand on your abdomen, so anywhere kind of around your belly button,
Okay.
take a deep breath in. Your nose is a helpful cue, so breathe in through your nose. You should feel that belly or abdomen expand out.
Mhm.
And then breathe out through your mouth and just let everything relax. So what you might see with somebody who struggles with that is um, they might suck in instead of allow the diaphragm to expand. They might kind of lift their shoulders or the rib cage or help themselves out with everywhere else. So that's one thing to look at. So sometimes we start with the breath and then we cue in some different contractions. But what I would say would be an easy place for just, again, like across the board, anyone to start with would be once you do that breath in, on the breath out, when you kind of just relax everything, just start to think about that pelvic floor or that bowl on the bottom. And there's no right or wrong. It's just kind of like, can you bring any awareness to what you think is happening there? Does it feel kind of stuck? Does it move? Do you feel air going anywhere in particular? Do you not feel anything? Does that make sense?
It does. Am I thinking about as I'm letting the air out and kind of the hammock, the attachments on either side, like on my hips? Is that what you're thinking, or
Mhm. Yeah, and you
are
can
you
even
thinking this way?
shift around a little bit. So if you think of also like a clock as a reference we use sometimes, whether it's where you're noting somebody has like a tender point or some tone. So if you think of that like your sits bones are the back of the clock and your pelvis is the front, and that circle, like are you noticing like, oh, I feel like I relax a little bit more on one side or the other, or not, or just
Mm,
sort of bringing
I
awareness
see.
to what might be happening.
Yeah, that is interesting. My right side is heavier. That's
Mm-hmm.
interesting.
Or you might even notice something like, depending on um, the incontinence symptoms or, when and where people are, to what degree people are feeling that, um, they might have some type of reaction that comes in that's almost like a clenching or an automatic, like, oh, I'm afraid if I like just do a deep breath and let go of everything that I'm going to pee. So now you're feeling that fight back that's just been like now a conditioned response. Um,
Is it easier to practice this breathing lying down, sitting up,
yeah,
standing?
that's generally where we start would be lying on the back with the knees bent and just
Okay.
sort of everything else is relaxed. So yeah, and that's how we assess like the pelvic floor function to start as well. However, not a lot of our day-to-day life happens on our backs with our knees bent. Um, and that's where either like a struggle comes in or multiple progressions come in, is that once people get the hang of it, they might come back and say, yeah, but it hasn't really changed my symptoms. And you might say, well, okay, well, you're contracting much better, you've got the hang of it, but yeah, you're still having incontinence because you're up on your feet and now gravity
Mhm.
has just changed things, or you've gotten tired and it's later in the day and you're lifting. So you do need to start incorporating it along the way. But it's a good place to start. And then generally the next step is whether it's just doing that breathing or it's a type of muscle contraction we're working on is um, do it sitting up, even driving in your car. And then you go to standing, and then you have people maybe doing a bit of a squat or cueing it with spinal movements in a cat cow position or something like that.
Oh, right. Okay.
Mm-hmm.
Yeah. Well, thank
Mm-hmm.
you. That certainly is a start into our pelvic health
Mm-hmm.
world and understanding. Kelsey, is this is this treatment covered under insurance, or how does somebody
Mhm.
access you or a pelvic health appointment?
Yeah, so it's no different than any other physiotherapy appointment. So, um, in terms of insurance purposes, I did have somebody once who said that for they had private insurance and for their insurance coverage, they needed a different note from a doctor that said it was required versus physio for something else. I've never really heard of that. To me, like a referral is
Hmm.
a referral to any kind of physio. However, I don't know. That's what she said, so that's a possibility. And that's a possibility with any physio is that the person's insurance provider might require some type of doctor's note or referral for them to cover the cost. However, you don't need that to come. So, um,
Yeah.
and then, yeah, there's no distinction between it being covered as part of physio. Sometimes I think it actually should be separate because you could sprain your ankle, and if you're only being given $300 of coverage a year, but then you require like they're kind of separate. But generally
Yeah.
speaking, I
Women's health. Yeah.
think physio is
Yeah.
so. Mhm.
It's an
And
interesting thing too, Kelsey, because if we have to go to our doctors, our GPs, or if you're lucky enough to have an OBGYN, that's a whole process to get to your
mhm,
physician to get that appointment.
mhm,
So that one, it may be automatically covered under your insurance. So physiotherapy under physiotherapy,
mhm.
correct? And there may not need a referral. A lot of physio, you don't need referral from a
Yeah.
physician.
And I think that's getting better because I think
Hmm.
they're starting to recognize the people that don't even have family physicians, let alone
Exactly.
specialists. So I
Yeah.
think it is getting better. But I don't want to say you don't need it completely because I think
Yeah.
there are,
So look into it and look
yeah,
into seeing the possibility. And then, of course, privately, you can book an appointment easily with you
mhm,
and
mhm,
just go straight in and have an appointment. And that would be, we would contact you through the TIHC website.
mhm. Or you can
Do,
call front desk, but they do the online
okay.
booking as well.
You're an online booker as well.
Mhm.
Great.
Yep, you would just want to make sure you select I think it's titled pelvic health assessment versus because the forms that get sent are different. Um,
Okay.
but we'd probably pick up on if someone mistakenly picks the wrong thing. And then,
Mhm.
like I said, to the front desk as well, um, if someone isn't quite sure or not sure if it applies to them, I'm happy to have a quick chat or a phone call or something.
Of course you are. Of course you are, Kelsey. You're so wonderful. Is there anything else that we have missed or you would like to offer our sisters at the campfire?
Don't think anything. I just think, I guess, reiterating that to not be afraid to kind of speak up. I think that um, if you feel like something is not right, and again, I don't want to point a finger at the medical system. Everybody's doing their best, but when we have kind of this luxury of time as a physiotherapist versus a doctor's appointment or someone who's got, that 5 or 10 minute time slot. So I think just in that, if you still feel like something's not ready for that, you need support, like speak up, find that service that may be helpful to you, whether it's, this is obviously one example, but um and then yeah, I guess just considering from like a bit of a preventative lens as well. Um,
Right.
mhm.
Yeah. Yeah. It being our own advocate for our
Yeah.
health and not feeling like we're being too much or
Hmm.
this is silly or my mom was fine and
Yeah.
everybody goes through this, or just some of the different myths that we've discussed. It's
Mm-hmm.
perhaps really encouraging everyone to listen to your body and get support. And again, the support can also open up other, what I call the symphonies, because the body is so interconnected
Mm.
that having professionals like yourself being on your team, your healthcare team, I think it's extremely important. Even when we talk about Dr. Ali coming in, having professionals like yourself and Dr. Ali supporting us through our health journey as
Mhm.
women and getting informed so we can make good decisions for ourselves and we can
Yeah,
be aware. I think it's just, I think it's our gift to ourselves
yeah,
that is needed.
I agree.
Well, thank you. Thank you so much. What
Thank you
a
for having
great
me.
experience.
Thank
Thanks for educating us. And maybe we'll see you again soon.
you. Okay, sounds good.
Thanks, Kelsey.